If you're like me, watching the news in the last couple of weeks has been like a punch in the gut. There have been several horrifying stories in the news revolving around mothers and the deaths of their children and postpartum mental health. And unfortunately, now it's part of the national conversation again. Now, when I was in grad school, I literally lived down the road from Andrea Yates. So I got to watch that unfold in real time in my backyard. And it's frightening to see that this subject has come up yet again with almost no progress between the problems of that tragedy and these. But I think the mistake we're making is how we're talking about it in the first place. We keep using phrases like postpartum depression and postpartum mental health as if we're describing one condition that only occurs after delivery. We're not. In some cases, we're getting that distinction wrong, and that can have disastrous consequences. So let me be absolutely clear about something before I go any further. I didn't examine any of the women involved. I don't know these cases in their details, and nobody else out there does either. Okay, I haven't reviewed their complete medical records. I'm not going to diagnose anybody based on a newspaper article or a Google review or an article that I saw off of Yahoo. Okay, nobody else should either. Anybody playing Dr. Google needs to realize that plugging this into a search and trying to justify an argument that you've already got an emotional response to minimizes both the medical complexity of this situation and the depth of the tragedy involved. So back up a second and realize that we need to think about this. Okay. You can't diagnose it off of that situation. Now, what we can discuss and the thing that needs to be discussed are the medical questions that these cases raise. Okay. So when a woman develops a major psychiatric problem after giving birth, what should we actually be looking for? Simply asking, is she depressed, is nowhere near enough. Certainly, we get that question a lot, both during and after pregnancy, but it's kind of like asking how you doing. It's not really giving you the depth of complexity you need. So it can be postpartum mental problems, can be many things on top. It could be baby blues that we know are largely related to the monumental drops in progesterone and from there GABA. Okay. It can be major depression or anxiety, which by the way are not serotonin based issues. They're much more complicated physiologically. They can have lots of different causes, including thyroid issues, medications, nutrient depletions. Serotonin can be part of it, but it's certainly not the only thing. And what's more is major depression and anxiety should have some kind of a precursor leading into them. So they should have had a mental health evaluation as part of their yearly wellness checkups from their primaries anyway. Postpartum OCD, bipolar spectrum illnesses, mania, psychosis, suicidality, delirium, any of these medically presenting psychiatric conditions need to have been evaluated and evaluated with some complexity, not just in kind of a passing fashion. But all of them should have evaluated for at least some risk during pregnancy, not afterwards. So let's be really clear on this. These diagnoses, from minor anxiety all the way up to mania, can overlap an awful lot in presentation, but they're not interchangeable. They don't carry the same degree of risk. And that's the big thing. And that's the biggest important mistake that you can make when you're trying to diagnose somebody that's being depressed, is that what we're actually looking for can be a ton of different things: bipolar activation, mania, psychoses, something that may be medically driven that happens to look psychiatric, for example. One important caveat to note in this, why that diagnosis is important, is because simply depressing an antidepressant, before asking these questions, you need to make sure that you screen for the right thing. Have we, for example, adequately looked for bipolar spectrum disease? Because if you put somebody with a bipolar spectrum disease on a monotherapy antidepressant, it can actually worsen instability and potentially precipitate mania or psychosis. Great. But that requires we will have done that work in the first place. And that's what needs to be done, is we need a more in-depth, a more complete evaluation of somebody's mental health before they get pregnant, during pregnancy, not afterwards when they have all these other exogenous stressors on top of them. So here's where the wording matters. Talk about a diagnostic overview. So here's two women, for example, and these are hypothetical examples, come into my office and say, I've had thoughts about hurting my baby. Okay, hairs on the back of my neck going up, a lot of concerns that I've got, but those words may sound terrifying, but medically, the next questions completely change the interpretation. So ask not what, but tell me more about that. Now, I'm not a psychiatrist, But this is where I help tell them if they need to go to one or not, and they need to have this conversation. So the first one may be saying, I'm getting this horrible image of a head that I may drop my baby. That thought may terrify me. I don't know what to do about it because I'm avoiding the stairs and I don't go outside because I may drop the kid on the sidewalk or something. Okay, that can be anxiety. It can be normal. It can be induced from a lack of sleep, but more worse, that can occur with postpartum OCD. Okay, so that is what we call an ego dystonic. Okay, ego dystonic, that it's unwanted. And it's horrifying to the patient, and she retains that insight. These are important things to notice before you start saying that somebody's, crazy. Now, compare that instead to somebody who says that, God's commanding me to harm my child. That's overtly wrong. Or my baby is possessed and I have to save the world from it. Okay, now we're talking about impaired reality. Okay, and that's where you need to get tested to see whether or not you actually know the world around you is real, because that's delusional and potentially psychotic. And the key here is that the surface statements can all say the same, right? What they say on top can be exactly the same thing, but until you start digging a little deeper, that surface statement doesn't really differentiate between them. And the physiology of the thought, okay, the patient's insight, okay, makes the risk entirely different between the two. Okay. So what I'm going to say is, before we start dealing with anybody else who may be dealing with this, we need to be asking these questions with a safety first mentality. To be clear, okay, if somebody's psychotic, if they're manic, they're suicidal, if they've got an inability to distinguish reality from delusion, okay, or they are a distinct danger to their self or their child, this is a psychiatric and medical emergency. Okay, this should have been identified and acted upon immediately so that safe acute psychiatric evaluation and appropriate treatment can come first. Now, that being said, here's where I think modern medicine sometimes makes a big mistake. Okay. Once we put a psychiatric label on a presentation, we somehow behave like that's all we need to do. The medical investigation's finished. We got a label, great, and we got a name for it. Therefore, we can just set it off to the side. That's not the beginning. That's not the end. That's the beginning. So I don't think that just putting a label on it is where it should be, because it's not a pill for every ill. So during the process of pregnancy, delivery, that postpartum period, okay, there are huge changes that go on in a woman. Her hormone levels shift dramatically from those sky high levels of estradiol and progesterone as they plummet afterwards and kind of bottom out. That's where, the skin goes shallow and the sleep goes away, and all of a sudden the depression kicks in. Those major hormonal disturbances are on a magnitude that you won't see again in your lifetime unless you have another child. That affects immune signaling, so they're going to be more likely to have issues with the flu or something like that. They're more likely to get sick. It's going to disrupt their sleep patterns. Certainly, the drop in GABA that goes along with that drop in progesterone causes huge issues in sleep regulation. And then there's just the day-night cycle disruption of having this 8-pound kid screaming every 15 minutes. That's going to throw off your sleep just by itself. Not to mention the stress of it's a completely new point in my life. Metabolism. Let's assume that they were perfectly normal beforehand. Now they may have some blood sugar instability. Blood sugar throws that off. Cortisol goes along with insulin disruption. Thyroid function. How many women have their thyroid deeply looked at? And I mean deeply looked at, not just TSH, but let's look at deeper markers. Like, did it disrupt a TPO if they're Hashimoto's, or free T3? And if that sounds like Greek to you, it shouldn't, because these are things that need to be evaluated on a fairly regular basis by any physician who's trying to go after these kind of cases. Then we get into the fun stuff like nutrient demands and nutrient deficiencies. There's an old German statement that says that a woman loses a tooth for every healthy baby born. The body will give up a lot of its endogenous nutrients just to try to keep the kid alive and healthy. So realistically, at that point, you're going to have some nutrient deficiencies just because you had a child. Okay. And then, of course, we get brain chemistry, which all those changes in neurons and neurology that's involved. So why would I suddenly stop investigating the physiology just because the symptoms that they happen to be giving me are purely psychiatric? Doesn't make any sense. A psychiatric diagnosis describes a syndrome. These are the constellation of symptoms I've got. But that doesn't necessarily explain every physiologic factor that made that particular patient vulnerable to developing whatever it is that was going on. So let's start with conventional medical differentials. Okay. First of all, thyroid function matters, and it matters a lot postpartum. And I'm never a big fan of using just TSH to measure thyroid function. TSH plus what they call free T3. That's the free and circulating hormone, not T3 uptake, but free T3 will give you a better idea how that actual thyroid hormone is being felt in the rest of the body. Right? Postpartum thyroiditis and autoimmune thyroid disease can produce really substantial psychiatric symptoms. And you have to be able to balance out that neuroimmune balance in the body. So I don't evaluate the thyroid in isolation. Look at free T3, look at the autoantibodies, that's TPO and TG antibodies, and those things can make a huge difference in terms of clinical presentation. And then, of course, put them in clinical context. Okay, what's the trajectory? Are they getting better? Are they getting worse? It looks like it's transient. Okay, what are their symptoms like? Okay, and remember, as I've said in other posts, that just because it's inside the reference range doesn't mean automatically that it's necessarily relevant to that patient. Okay, treat the patient, not the paper. Okay. Then we get some fun stuff when we start moving on beyond just those tests. Let's run into hormone fluctuations. Okay, the abrupt transition from a high estrogen, high progesterone state after delivery, where they bottom out. Let's talk about the effects upon your neurosteroid biology between your cortisol levels and your basic neurotransmitters, your serotonin, dopamine, epinephrine, norepinephrine. Are they in balance? How are my adrenals doing? Certainly, they're not going to handle the day-night shift very well if I'm overly stressed. Okay. Hormone metabolism also becomes a big issue. How am I breaking down my estrogens? Sometimes it can look like you've got a huge amount of estrogen when you're actually just not breaking it down correctly. Or if you're breaking it down too quickly, now you may look like you've got plenty, but it's essentially passing straight through. So you need to take a look at urinary hormone metabolites. They gave an additional view of steroid metabolism in this. So, for example, I'm not going to merely ask, is my estrogen technically normal? What I'm going to ask is there an endocrine transition this patient's just gone through in terms of how she metabolizes those hormones? Okay. And does that pattern make sense in terms of what we're seeing clinically? Does that make sense in terms of what we're seeing clinically? Okay. Now understand, none of these things diagnose postpartum depression or postpartum psychosis, but they do answer a different question about endocrine physiology, right? How is the environment going on in this patient that's leading them down that direction? Now, then we get into some fun stuff. We talk about how your autonomic nervous system is operating and your neurotransmitters. So remember, a new mom may be incredibly sleep deprived. You generate a lot of your neurotransmitters if you're getting good sleep. If you don't have that, you're not going to get the right balance of neurotransmitters in your body. Okay. As a consequence, we need to evaluate, are the neurotransmitters being produced in the right levels? Okay. And two, how are they operating within the brain? Do we have what we call an autonomic dysregulation? That's a really big word that basically says, do you have more sympathetic activation, your fight or flight mode, or do you have poor parasympathetics instead, your body's ability to calm things down, sort of a feed and breed mode? Okay. So in that balanced scale of excitation versus relaxation, do I have what it takes to be able to get my brain back to a balanced point? And by the way, this isn't just postpartum women. Everybody can have these issues, and that can lead into hyperarousal, hypersensitivity, anxiety, various forms of physiologic stress. By the way, you can look at that. Heart rate variability gives you the technical ability to actually look at your autonomic nervous system. Do you have that fight or flight versus feed or breathe, the sympathetic versus parasympathetic balance? You can actually look at the brain waves involved, and then correlating those with neurochemistry, you get a better idea of how the brain's going to operate given certain stresses. Again, this doesn't diagnose psychosis, bipolar, postpartum depression, none of that. Those are syndromes. Those are psychiatric diagnoses. What we're doing is we're trying to get a physiologic data point, okay, along with autonomic regulation that tells us how the body is actually handling all of these stresses. So what I really want to know in these patients is if a nervous system can appropriately move between activation and recovery. Does it have a chance to turn off? Are they essentially physiologically living with the accelerator slammed all the way to the floor? These are important points to ask when you're dealing with that patient in this situation. So you may want to take a look, for example, we've talked about activation of the nervous system. Let's talk about the actual neurotransmitters. There are neurotransmitter patterns that need to be looked at. Your dopamine to norepinephrine to epinephrine ratio, what we call the catecholamines, is that entirely slammed to the floor? So all you have is a pass through from no dopamine, where you're not feeling anything, all the way down straight down to epinephrine, where everything is a threat against you. How are we doing with serotonin? That's not the only problem, but serotonin is inhibitory. It calms you down, but so is GABA. Do I have problems with glutamate? Okay. There's a whole host of neurotransmitters that can be evaluated through urinary excretion. And again, let's be careful. Urinary excretion of neurotransmitter metabolites is not a direct measurement of neurotransmitter activity inside the brain, but it tells you general trends. It will tell you whether or not there's an overactivation. There's a reason in medical school they teach you what's called serotonin syndrome, where you're taking things or medications or supplements that upregulate your serotonin. And you could see that on urinary excretion. You could see that those serotonin metabolites go up. You need to know this because it tells you whether or not you've been developing serotonin syndrome. Doesn't it make sense we can see trends in those neurotransmitters that might then be able to say, okay, if the global levels of these neurotransmitters are moving one direction or the other, then I can expect that this patient's going to be more excitable or more depressive or more prone toward that differentiation between right and wrong. Yeah. And I think that because we have these technologies, it's germane, it's ethical for us to actually take that leap, okay, and use those technologies to be able to better evaluate these women. Now, I would never present that any of these things, again, are diagnosing these conditions, but they give you the physiologic context of the symptoms, of what they're going through, so you can evaluate what's the medications doing, what are their hormones doing, what are their sleep doing. Okay. All of these things give us another piece of the physiologic picture that allows us to be able to figure out ways to help these women out who are going through this post delivery. But our problem is that we're treating every laboratory result as an independent problem, not a solid diagnosis. The value, particularly in a neuropsychiatric format, comes from the integration of what they're feeling and what these integrated things show. So, for example, we may go from there into an evaluation of the gut. Right now, what's the gut got to do with it? Looking at things like short chain fatty acids, microbial metabolites, looking at immune signaling and various neurotransmitter associated pathways. Okay, might be able to give some context about what's going on. In the literature, dysbiosis, the imbalance of good and bad bacteria, have been shown to be associated, not causal, but associated with postpartum depression, and that's in several studies in the emerging literature. Again, that's not saying that your neurotransmitters and what's going on in your gut are entirely driving this forward, but doesn't it give us another tool to evaluate them with? Doesn't it give us another aspect to be able to help these women out? And if we've got that ability, shouldn't we use it? So again, none of these things diagnose postpartum depression, but I think that pretending that the gut and the immune system and the brain and the neurotransmitters exist somehow in these independent silos and unregulated boxes doesn't make any physiologic sense. We are one organism, one person, all put together. So if we're looking at that complicated patient postpartum, and when you're looking at these women on the news, I think that's something we need to keep in mind. It's a complicated presentation. And I don't think the answer is necessarily psychiatry or physiology. I think our question is, what psychiatric syndrome is present that needs to be evaluated based on a level of risk, and what's the immediate level of that risk necessitate in terms of our responsibility as healthcare providers? Okay, what conventional medical conditions have to be excluded? Okay, are they running through a variety of withdrawals? Do they have hyperthyroid or whatever else? But once we've established that safety, then we can go back and ask the deeper questions, right? What do their hormones look like? What do the breakdown products of their hormones look like? What's their nutritional status look like? What's the autonomic balance in their brain, the fight or flight versus feed and breathe, the sympathetic versus parasympathetic? What's their GI look like? Do they have a food allergy? Do they have a dysbiosis? Do they have something going on in that gut? Okay, that may be contributing to that patient's vulnerability or a lack of ability to recover from the stress of pregnancies. And all of those questions are different, and all of them matter, because when you're dealing with the complexity of a human being, you have to respect that complexity is something that is individual. It can't be mass produced across everybody, and it needs to be reflected as an individual need, and it needs to be evaluated by the proper providers who can actually look at that. So I think one of the biggest mistakes we made in medicine is treating mental health and physical health as like they're two totally different things. Okay, a psychotic patient still has a thyroid. A depressed patient still has an autonomic nervous system. And a woman with postpartum anxiety still has hormones and immune signaling and sleep physiology and a GI tract and metabolism and all those other things. Psychiatric diagnosis matters enormously, particularly with risk management, but it doesn't erase the rest of what's going on in the patient. We need to stop treating mental health and physical health as if somebody drew a line between them at the neck.